Statins may be the single most important advance in treating cardiovascular disease in our lifetime, yet there are many unanswered questions. Who should be taking them for primary prevention, and starting when? Does the addition of non-statin therapy also decrease risk? What is the cost effectiveness of a more aggressive approach, and even how low should we go anyway? So the December 6th issue of JACC offers an important look at some of these questions, and it's determining when to add non-statin therapy, and it is a quantitative approach. So to do this, I'm with one of the authors, Dr. Jennifer Robinson, MD, MPH, who is a professor in the departments of epidemiology and medicine, and the director of the Prevention Intervention Center at the College of Public Health at University of Iowa in Iowa City. I used to hang out there when I was young. It's a great place.
We have many
I love
great
that
experts
place.
from the state of Iowa.
Exactly. So clearly there are a number of important questions. Let's start with this one. Why did you conduct this study?
Well, the ACC has a non-statin clinical care pathway that was recently published, and I had participated in early stages of that and spent a lot of time thinking about, well, who should we add non-statins? And I was one of the vice chairs for the cholesterol or statin guidelines that we released, which really emphasized maximizing statin therapy in patients who are likely to benefit. But then what do you do after that? And so the non-statin pathway was developed to kind of help provide some guidance. They did identify patient groups, so clinical cardiovascular disease with complications is a very high-risk category. Cardiovascular disease without complications, kind of a high-risk category. Cardiovascular disease, a number of groups. And then they used the idea of LDL thresholds, which we had earlier kind of started promoting as a better way to think about triggering. Should I add a non-statin? I mean, is the LDL above? Not do I need to add one to get less than 70, because that means the LDL is 72. You can add a gram of niacin and get to, it just leads to the wrong thought processes. So we thought, LDL over 70 could trigger adding a non-statin in very high-risk people, clinical cardiovascular disease with complications. So I thought, I think we can do a better job than that, because I think there's a lot of difference between 70 and 170 in terms of who's going to benefit from adding a non-statin. So we and this is a continuation of our guideline work, thinking about the potential for net benefit for that patient. So we did a number of methodologic things. We did a systematic review to find all the event rates of statin-treated patients in clinical trials. And you would be interested to know a very high-risk patient, cardiovascular disease with complications as defined by the ACC pathway, CVD plus diabetes or CKD or FH, all those groups, they actually have on statin an extrapolated 10-year risk of 30% or greater on a statin. Wow. Very high risk, so clearly a lot high-risk patient. And then what we said, we also know from the cholesterol treatment trialist meta-analyses, from Improve It, and now the PCSK9, they all kind of plot on that line, a 40 milligram per deciliter reduction in LDL, you get about a 20% reduction in events. So it's the magnitude of LDL reduction. So knowing that, very complicated, but it's all you need is an NNT. You can calculate a number needed to treat based on the risk of the patient, where their LDL is, and what you add. So for example, a very high-risk patient whose LDL is 190, and you add ezetimibe for a 20% LDL reduction, the NNT is about 33. If their LDL is 70, the NNT is 88. So you probably don't want to add ezetimibe unless it's just not worth it. How about PCSK9 inhibitors, which lower LDL 50% or 65%? Well, that same 190 patient, adding a PCSK9 inhibitor, you get NNTs of 10. I mean, that's where the value is treating high-risk people with high LDL. So you can work through, it's all worked through in the paper for people. But to make it easy, you need a calculator, and we just got funded to do the calculator, but you can still use the pathway.
Now, I walked into your session this morning, and it was really interesting, because one of the things you had said, which I didn't realize, is that statins may increase PCSK9 in the body.
Yeah.
And so the idea of a statin combined with a little PCSK9 inhibitor might not be a bad thing.
Oh, it's a good thing. You get the full efficacy of statins, you get another 10 or 15% reduction of LDL adding a PCSK9 to a statin than as monotherapy. So it's like a win-win, you know. So the take-home message is don't let those statin-intolerant patients get away with it. You tell them you need to be on some dose of a statin because it's going to help your PCSK9 inhibitor work even better. But, you know.
So I guess the message is, in the last couple of years, we've seen so many things like niacin. They just it's fallen apart at the seams because it just doesn't work. So the lesson to learn here is not that nothing works except statins and maybe PCSK9s that are too expensive, but that there actually are things you can do, non-statin therapies, that will help.
Lower is better, probably for LDL, but it matters how you get there and in whom.
And the cost effectiveness issue,
Right,
how's that?
Right, so the ezetimibe is going to be off patent and it'll take a couple years and it'll cost less. I don't know what I'm sure they'll still charge for it. It won't be $5 a month. But the PCSK9 inhibitors, the monoclonal antibodies at least that we have FDA approved now are about $14,000 a year. And of course they get discounted and all that stuff, and they're probably less than that. But even any scenario, they're really not cost effective in everybody whose LDL is over 70. And what we really want people to do is go look at what that NNT is, because that's how many events you prevent for that dollar is what's going to drive what the payers are willing to pay for.
You probably haven't even seen this yet, but there's an editorial comment to your paper, Bringing Structure to the Art of Lipid-Lowering Therapy, and it's by Todd Anderson, MD of the University of Calgary. He calls it an elegant tour de force manuscript.
Ooh!
So,
thank you.
that is from JACC, so please go to the JACC December 6th issue and where you'll see this paper. And I can't get away without saying that we should note Lloyd Jones and his colleagues recently published the ACC algorithm that we talked about, and that is a 2016 ACC expert consensus decision pathway on the role of non-statin therapies for LDL lowering in the management of atherosclerotic cardiovascular disease. That is the July 5th issue of JACC. So for CardioSource World News and CardioSource World News Interventions, I'm Rick McGuire.